Hi, everyone, and welcome to the Collateral Nation, where we typically talk about walking as medicine. Today, we have a very special guest. We have Catherine Noggle. She is a researcher out of the UK, and she has a very special opportunity for everyone to participate in her latest research project and to help influence the change that we all want to see in care for PAD. She's very passionate about PAD. And you might wonder, we don't hear about PAD on the street. When we talk to people, they're like, wait, what? What? What's that? Wait, oh my gosh, there's someone that's actually interested. Yes, so we got to find out why. What was the catalyst for her interest in PAD? Because although we'd like it to be the norm, it's just simply not. So I hope that you will honor her with your participation in her research project to hopefully inspire her to do more and more and more to help us create the change we want to see and improve care for PAD, not only in the UK, but across the globe. Catherine, welcome. Thank you so much for being here.
Thank you so much for having me. I'm really excited.
So give us a little bit of your background and how you fell into PAD.
So I have a bit of a mixed background. So I have an undergraduate degree in biomedical science, and then I've spent a good bit of time working in hospitals as a nurse's aide. And right now I'm doing my best to get a doctorate of physiotherapy. And as a part of that, we get to choose a research topic. And I was sort of looking at different topics available and who is in and who worked in the university. And Christinen was actually my personal tutor. So he was someone I had actually already spoken to. um,
I see how it is now. He has the most contagious energy. You know, he was our global walking research, um, walking therapy researcher of the year for 2024 globally for the Global PAD Association. I mean, his passion for PAD and what he's doing to help improve the care is incredibly contagious. So it's amazing. And I know he's there sitting in the background. He may chime in a couple times during our interview here, but definitely, I'm so glad that you hooked up with him and that his energy was contagious and rubbed off on you.
yeah, for sure. And I was already really passionate about patient-centered care and chronic conditions. So it just slotted in really nicely for me. Just yeah, everything about PAD and hoping to kind of research that and improve the care for it in the UK.
So, what is the focus of your research? I mean, there are so many different aspects, right? Even when it just comes to physiotherapy, what is your focus and how did you decide upon that specific focus for your research project?
So I'm looking at the to investigate the treatment experience. So of people with peripheral arterial disease, specifically in the UK. So there's research available kind of on how do healthcare professionals in the UK feel about treatment for PAD? How do various different groups feel. And in Europe, there's quite a bit of research about how individuals with PAD feel about their treatment. And um, that wasn't available in the UK. And obviously, the UK has its own system, it has its own specific quirks of the NHS. And in other countries like Sweden, these sort of in-depth investigations have really managed to spur change in how treatment was conducted and provided. And I just thought that when you look at the research and you look at the body of evidence we have right now, it's obvious that treatment could be better in the UK, but we don't know how. Um, so that's kind of what I was hoping to figure out.
So, what is the role of the patient in this entire process?
um, as in for my study during my study.
Right. What are they going to have to do? What does participation look like in your research project? Some are just surveys, some are Zoom calls. What would that look like in terms of participation and even what is the time commitment?
So from the beginning, so you would sign up, and book in a slot for an interview with me. So interviews will be probably anywhere from 45 minutes to an hour. There's no time limit. It really just depends on how long we chat for. But it would just be this single interview. We're hoping to maybe contact people in a year's time and talk to them again. But that's something that they can say, yes, I want to do this, or no, I don't. And of course, in a year's time, they can change their mind and say, actually, I don't. So at the minimum, it would just be this one sort of hour-long interview with me on Microsoft Teams. It would be recorded and at a time that the person chose.
Wow, you literally just made YouTube producer's entire day when you said Microsoft Teams and not Zoom. He'll probably start doing thumbs up in the chat. So I'm curious, with these interviews, and I always struggle with this because I do interviews all day long. How do you quantify that information? I mean, do you have little check boxes that you have? Do you have any sort of preconceived kind of like idea as to what those answers might be? And you'll have little tickers, little check boxes to say, oh, they talked about this. Oh, they talked about this. Oh, they talked about this.
So I've got 10 topics that I kind of want to cover. So I'll probably ask questions around those topics, just as they naturally sort of come up. Um, and it's just 10 topics surrounding like treatment. It's like, what was your diagnosis experience like? How's your GP managed your condition? And just wanting to hear about the experiences of that. So I might ask little like more questions just to get a bit more of an in-depth idea about it. I don't have any preconceived notions about what the answers will be. That's why I'm doing it. So yeah, just those 10 topics. And I'm just aiming for it to be really conversational. So just sort of a back and forth, hoping that people are happy to share with me, really, because I'm just really interested in their experiences. So yeah.
It's really good at a time when patients are always telling us, I wish someone would listen. Here's an opportunity where someone is listening and is willing to try to do something with that information that they're hearing. And that's really huge. So you're not falling upon deaf ears when it comes to this conversation that these patients are going to be having with you, Catherine, correct?
Yeah. So
That's the
once
whole idea of the research.
yeah. Once I've collected some data, hopefully I will kind of compile it together and see if there's things that a lot of people said, for instance, like this really helped me or this is really difficult. And then once that's sort of compiled and established, it can be used, hopefully, to implement some real changes in how treatment is delivered, or at the very least, it'll be out there, right? So somebody hopefully can read it and it can
It'll
move
be
things in the
evidence.
right
It'll be
direction.
some sort of evidence that's out there, and
Yes.
everyone's looking for evidence. So you want evidence, it's coming. It's coming. You want to know how to treat patients better? Just wait. These interviews, I think, will be very powerful because I know the crew that we have in our groups, and they're a very dynamic, influential bunch with incredible stories that should be heard. And I appreciate you giving them the time. But what are the parameters around the their participation and the use of their name and their contact information? It's something that is very important to them.
Yeah, completely understandable. So, the parameters for who I'm looking to talk to is quite wide. So anyone who is over the age of 18, has peripheral artery disease or thinks they do, sort of lives with it, and who lives in the UK and receives treatment or yeah, receives their healthcare from the NHS. Um, so um, quite wide. And for names and contact information, so the names and contact information will just be known to myself and the research team. So my supervisors, Christine and Philippa Dahl. And those will be stored only if the people consent to being contacted in the future. So either if they want to see the results or if they want to be contacted in a year's time, then those will be stored. But in the published results, no one's name will be in it. I'll do my best to make sure no one's particularly identifiable. It's anonymous after the interview.
What would
essentially.
be great is if you could name, just as a supporting partner, as something, the Global PAD Association's UK group on Facebook.
Yeah, I would be happy to do that. Absolutely. Yeah.
If we can get more participants. So how many participants are you looking for, and how can they contact you if they're interested?
So I'm looking for 8 to 10 people. I'm happy with a little bit more, a little bit less. I'm not really fixed on numbers. Um, and once all my paperwork is in order, I'll be posting an ad to the Facebook group with links and contact information. But if anyone wants information now, my email is cnagel, Nagel 300 at caledonia.ac.uk. Um,
Yeah. And I think that Kathy posting is probably going to be more influential. So I would give her the information, because our friend Kathy here is very well trusted, and deservedly so, in our group. And so when she posts, people listen. Yeah, well, as your mentor, Dr. Christine, found out with his study he did, and all the participants, I think we got him a lot of people participating in his latest survey.
Yeah.
Would you be willing to share the results once all is said and done, and thank our group for participating in your research? Because as Dr. Seenan has learned, that our patients just love when you come back and say, "Oh my gosh, I'm learning this and I'm learning that," and share it with the whole group.
Oh, absolutely. If there's interest in that, I would be super happy to post the results to the group if that's something that's wanted. And like I said, any of the participants who want copies of the results will get that as well. Um, and absolutely, I will be thanking the group in my final work. It wouldn't be possible unless you guys are happy to talk to me. So I'm very, very thankful.
Well, you're very pleasant to talk to. I can feel your contagious energy, and you're just so excited about this. Is there any story, and I know I didn't kind of show this ahead of time, but I'm curious, was there any story that seemed to influence this research? Have you met with a patient that's had PAD? I think I heard you might have talked to Kathy as well. And I'm curious, if there was anything about her story that just inspired you so much more, and was maybe a driver that let you know that this is the right direction that we need to go. I need to do this.
Yeah, Kathy agreed to chat with me, which was really thankful, which was really helpful. And yeah, it was really affirming. I was like, amazing. I'm able to listen to this, and I'm learning so much from this. Like even just from that one interview, I learned so much. And Kathy had fantastic feedback. She was like, maybe talk about this, maybe talk about this. And I've already worked those into my questions and the things that I'm going to be approaching. So it's just yeah, really fantastic
You
to
know,
chat with.
that's really amazing to hear. Just that you're adaptive, and that just the conversation that you had with Kathy. And I think that this is important for everyone to hear. Just that one conversation with Kathy, where you listened, you heard her story, and then you adapted your research because of what you heard. It's not often that you hear that, and I think that that's a really powerful statement, and I think that it would influence a lot of people to join your study, because they know that they're really going to be heard, and influence what you are doing. So that's really amazing. I want to hear from Dr. Seenan really quick as we close out. We covered so much, and I really appreciate you being here. And Dr. Seenan, thank you so much for inspiring this wonderful new researcher here to get into PAD and try and help us create the change we all want to see.
Yeah, no, it's just fantastic that Catherine was keen and interested and has been a brilliant student and a brilliant kind of taken a really impressive approach to this study. And I think it's such an important study. It's such an important thing, kind of jigsaw piece in the whole story where, we all want to improve care and improve quality of life for people living with PAD. And to do that, we almost, before you can try and fix a problem, you have to understand the problem. And so that's what where this is headed. And it's kind of say, we know that care is not perfect anywhere in the world. But we can start where it's feasible and possible to start. And that's where we're starting in the UK. we're starting with the experts. We're talking to the people that are living day to day with this condition and want to know their story and their experiences. And so we can learn from those experiences, figure out where things are going well and learn from those, figure out where things are going not so well and what we could maybe do as an alternative. And I think that's what Catherine was noticing from her chat with Kathy was about all the different things that Kathy has picked up or done or figured out herself on top of, or in because she's not maybe been provided with much input or kind of ideas elsewhere. So it's how what kind of things have you figured out yourself to kind of help manage your condition?
I want to bring in a few of the PAD warriors that are here. We have Patty here, and I love Patty. Your name is just perfect. PADDY. Patty is actually our mascot too. So and we have a little heart man, heart woman, neutral um, gender, a little heart person. That is named Patty as well. PADDY. Patty, do you want to go ahead and unmute? Patty really wants to participate and would love for you to take a few moments, Patty, and say hello and just share a couple little nuggets that would, um, be really powerful and influential about your experience.
Cheers, Kim. I haven't really participated much in the group, but I found your information just extraordinary. It was a real game changer for me. I had a holiday quite a few years ago, went to Portugal, and I just couldn't deal with the hills and walking, which I'd never really had a problem with before. So I came back, I knew something was wrong. And I kind of spent a lot of time really self-diagnosing that I had PAD, I had claudication, I had all of those things because I wasn't aware whether I should be going for massage or any therapies. And I went to the GP and they were singularly uninterested, really. Didn't know what to do, suggested physiotherapy. Um, and then a year later, or several months later, I went back saying, look, I really think I have PAD. And the doctor then I went to said it was impossible. I couldn't have PAD because none of my toes were black. So that kind of spun me. I then had a Doppler test and I was given a point 0.4, which is kind of urgent. So
Yeah.
the NHS said yes, they would deal with it urgently, and then I was told I would have a reference within 6 months. So I found out who the vascular surgeon was. So I went to him privately and paid privately for that. And he gave me, he confirmed that I had PAD. And I think I'm in this position where I'm pretty healthy. I cycle, I do a lot of exercise, I do stuff. I didn't know that walking was so integral to recovery, or at least keeping stuff in abeyance. And then I had the same doctor. I came up through the NHS process, and the same guy didn't actually see me. He just used his notes from my private consultation and said, oh, well, there's nothing we can do for you now besides putting me on clopidogrel and a statin. Months later, I went to a podiatrist and said, look, I really want to work with this. Should I get massage? Should I really work it? So they sent another letter to the GP, who then referred me back to vascular. So I'm in a position where 3 years in, I have had an MRI scan, which was in September last year, and I have not had the results back yet.
Oh my gosh. Are you kidding?
Yeah.
So you're sitting there with a 0.4 and you still
Yeah.
haven't gotten any treatment yet.
No. Well, besides clopidogrel. I think that's why I'm interested in the research and why I've found your group so useful. I remember Kathy talking about her experience of having had PAD for 20 years, and I thought that was just the best news I'd heard for a long time, because I kind of expected just from
Yeah.
reading. Dr. Google is full of very scary information that I would
Right.
be
Dr.
crippled
Google
within a
says
short time.
once diagnosed, you'll be dead in 5 years.
Yeah.
And that's just
So,
not true.
so that's where I'm at. So I'm looking forward to possibly participating with Catherine's research, just because I think my experience, because I'm kind of working hard at trying to do the best for myself. I don't expect a lot of medical intervention if I can do stuff myself. So I'm in
How
that
empowering
situation.
is it, Patty? How empowering is it to know that you don't need an intervention, you don't need surgery, that your health, your prognosis is in your hands?
Well, that took probably only through working with your information, that my GP on the 2 or 3 times I've been there are singularly uninformed. If I say, look, should I just plug ahead with walking a lot? They kind of just go into a blank space saying, I haven't got any critical, but my toes aren't black. I think they're looking forward to that period because then they can do something. But without any real signed information. So I'm looking forward to the MRI scan where I could see from the person doing the scan that they could see that there were blockages, but I don't know
You
where
know,
those are.
that's so interesting. I just had this conversation with a doctor yesterday at Kaiser Permanente in the San Francisco Bay Area, which is an HMO hospital system. And we were talking about how busy the primary care doctors are and this and that. And um, I said, gosh, it'd be really great. Just 2 fingers, 2 seconds to feel the foot pulses, the leg pulses, and life and limb could be saved. Would take 2 seconds, but you don't want to add that one more thing to these doctors. And so the conversation evolved into, well, you know what, if you catch these patients early, like, what do you do? What is out there for them? What is the protocol? And
Mm.
I think that could be a hindrance for these primary care doctors. I think you hit the nail on the head that, well, what do we do with you? I can't really send you to vascular because vascular can only do interventions and surgery. Like, where do I send you? And I think the answer is going to be, for all of these people that are being diagnosed early, well, let's put them in Dr. Chris Seenan's hands. Let's get them to PT. Let's start them early on a walking program and teach them how to keep their legs long term and never need a procedure down the road. Dr.
Yeah.
Seenan, what do you think?
Yeah, absolutely, and it's your experience, Paddy, is really interesting. But I think it's not uncommon. Unfortunately, I think it's the experience of many people, and a couple of things that it highlights to me is that, for one thing, I think primarily is the kind of understanding and the awareness or familiarity or confidence of healthcare professionals to kind of know what to do in this situation. In the UK, as is in the US and other areas, other countries around the world, there are really robust clinical guidelines about how to manage this condition. So there is a bullet point list of, if the person presents with these symptoms, do this and that and that, and you do this first and then that and then that. And so, it's almost, the information's there and the evidence is there. The research has been done. We know what works in these situations. The fact that these clinicians, I don't know if it is because it seems like a specialism and it's something, especially, because vascular surgery is a really, it is a specialism for medics and surgeons that work in it, and whether, GPs and other healthcare professions are just kind of a bit worried about making decisions or thinking. But so there's something there about how can we educate more healthcare professionals about how to manage, and but also it's perhaps, as you say, maybe they don't feel there's anything to offer apart from the medications they've been put on. So how can we design services or opportunities for people to engage with regular physical activity and find a community that will help support you kind of managing your condition
Yeah.
for the foreseeable future.
Yeah.
Yeah,
No,
thanks very
I
much.
agree 100%. And I'm
I
curious,
remember once with the GP when I said I was getting really good information from an American-based group called Pad Support, and she kind of looked at me and said, um, "It it could be more harm than good."
that's what they always say. And it's
Yeah,
interesting. And I agree
a
with her
support group
actually,
of
with most of the
yeah,
groups that are out there. Most of the groups that are out there, it's like the blind leading the blind. It's a group of patients that are just struggling themselves, that there are several that are on soapboxes that are looking, to provide advice to only to affirm their own experience versus really understanding PAD. And so the way we designed our organization is to really involve the doctors and the clinicians and the people that really the experts in this to help to facilitate moderated conversations. And so we have people like Kathy. Yes, she's a patient, but she is working right there under, and alongside Chris and his team, and she has the right information. She's on the front lines with the research. It's very different than, for example, there are diabetes groups out there where you have patients that are telling other patients to follow the keto diet and only eat eggs and steak.
yeah, yeah, yeah,
Literally. And I'm not
yeah,
even kidding, because that's what they're doing. I mean, where are the fresh vegetables and wholesome foods? It's just a group of 40,000 people where it's a heart attack waiting to happen. So we really wanted to provide a safe place that was moderated and facilitated by, with clinicians and physicians. And they tell me, I get messages from physicians saying, "Hey, did you see this in the group? Make sure to get in, make sure to say something there. You need to change this or do that." So I would agree
No,
with
I
her
mean,
for the
that's
most part.
phenomenal. And I'm really pleased that there's a sort of more present UK sense of that because reading through a lot of your posts and a lot of the people part of it's a different world. You were talking about the specialisms that we don't seem to have access to.
Yeah.
And you were referring people to London, and then that Italian guy left. And, there seemed to be a vacuum in terms of where to go and what appropriate. I mean, in my situation, I don't mind going private if
Yeah.
I need to, but I respect the NHS, and I think that if people had the right information, that the treatments would be improved. But the
What's really
timelines are
difficult about the
problematic.
NHS is you actually have some of the top doctors and researchers in the world on PAD. It's a very different culture, I think, than you see here in the US, in that here it's a little bit easier because the doctors can be up on the pedestal a little bit more. If you put a doctor in the UK on the pedestal, boy, they're quick to be brought down. They,
Yes.
they don't like to, for example, with Dr. Lorenzo Petrone. I love him. He is incredible. He's one of our senior advisors here at the Global PAD Association. He's plays such an integral role in helping to guide us to make sure that we are putting the right information out and guiding patients in the right way. But when we made him our first global PAD Doctor of the Year, and they put it out there in the NHS, man, it was like, right on him. So it puts a target on their back. So it makes it more difficult. But he actually now has a conference called FYA, Find Your Algorithm Conference. And it's a really good conference for you to actually be able to go to their website and check to see who's speaking. Because I've been to this conference now 2 years straight. And this conference is where they have some of the top doctors across the globe who are sharing the most advanced tools and techniques with other doctors at this conference. So it's a great place to wink, wink, nod, nod, for you to go to see who in the NHS is not only practicing with the newest tools and techniques, but they're also teaching others those same limb salvage tools and techniques.
Gosh,
Just a
okay.
little tip.
Thank you.
And I want to bring in, thank you, Patty, so much. I wanted to bring in, where's Catherine? I didn't know if she had any thoughts or comments or questions based on what she heard in the conversation.
Excuse me. Um, I think that is a really like for me that's a new experience, which is part of why I'm really interested in hearing all these people's stories. Like the combination of private and public healthcare and needing to go private is obviously something that is really important and should be addressed. So mostly just thank you so much for sharing that, and I really hope that we get to speak again.
Definitely. And we'll make sure that you both are connected. I can give him your email, and Kathy can also connect you with him. And Lynn is also here. Lynn, thank you so much for joining us. I'm sure you probably want to participate in the research as well.
Yes, absolutely. I'd be happy to. Yes.
Fantastic. Do you have in just the Cliff Notes version, the short version of your story and a couple things that she might find interesting about your experience?
Well, where I am at the moment, so I'm a year post diagnosis that I had to go privately to get. Otherwise, I think I might have still been waiting. Um, at the moment now, I just feel been left a bit high and dry now. I don't know what happens next. I've never had a Doppler. I've never had an ABI. I just had oh, sorry, I don't even know the name of the little thing that they run up and down your legs now. It's completely gone. And he just said, yes, he could hear a bruit.
Ultrasound,
And
I guess.
Yeah, the handheld Doppler.
that's right. Yes, thank you. And just sort of like put me on clopidogrel and a statin that I'm currently struggling with. I'm on my third statin now because they make me feel very ill. And but I don't know what kind of happens next. I guess with me, it's like, do I just wait until it gets worse? I mean, I hope it doesn't get worse. In fact, I think I've improved, with my walking regime. I'm certainly not in as much pain as I was. I can walk further. So that's really positive. And like a lot of people have said, Kim, all this information I got off of your off of the Facebook pages, I wasn't ever given any information, even from the private consultant. So at the moment, yeah, I'm a year in. I don't know whether I'll ever be reviewed, what I have to do to review, whether I can just ask for one, or whether that'll be considered a bit of a pain in the neck if I do. I would really like to know if I have managed to build collaterals. I'm only thinking I must have done because the pain has lessened. But
That's how you tell.
it would be really encouraging to know that I was. I don't know whether you saw my note that I put on the chat. I'm noticing a lot of people now on specifically on the UK chat are being offered surgery as a kind of a first resort. And if I can just say that when I was told that I'd got PAD, I wanted surgery because I wanted it to go. I didn't want it. I wanted to be well again. And I could have made a nuisance of myself, but instead I went home and kind of absorbed the information and luckily found your Facebook page. But I do wonder now. I mean, I had a conversation with the chap yesterday, and he said he'd seen 3 doctors, and they'd all said he'd got PAD and he wants to get better, and so he's going to have this surgery. And I think he said he'd only had it about 3 months. I mean, if it's taken me a year to get to where I am with the walking regime, it's just a bit worrying because so many times it goes wrong, doesn't it? I know it
Yeah.
gets better as well, but it's intrusive, isn't it? And just so many times it goes wrong. It just worries me really that people aren't being given the right information.
It'd be interesting, Catherine and Chris, is to do a study on our group and find out what it was about what we've said. And I think it all has to do with walking, but what is it about walking that we said, or the way in which we said it, that really influenced them, that had that impact? Because I know that doctors tell patients, oh, go home and walk, walk, walk. But what is it about what we've said? And I know that, you know, Dr. Sini, I mean, you've been an active participant and you've played an integral role in influencing that and with the information that you have also provided, in our network. So that might be kind of fun. Just to, if we can drill down into what works and then maybe put it into a little pamphlet to give to these primary care doctors to give out to the patients, not only in throughout the NHS, but across the globe, which would be
Yeah.
kind of fun.
Yeah.
Tim, I wish you'd have seen me a year ago. I wish I'd have now videoed myself a year ago, hobbling down the garden and having to stop, and now I'm on the walking pad and I'm doing at least 2 miles a day on the walking pad, and then probably adding another mile and a half around the house. I wish I'd have done that now, really, just to prove to people that it does work.
I love that. I
Mm.
can see Chris smiling. He's
Yeah.
like, yes, it does.
I think it's fantastic, and as Kathy said in the chat as well, the evidence that you're suggesting there, Lynn, and that improvement, it means that the walking is working. It does sound as if you are building collaterals, or at least training your muscles in your legs to kind of work more efficiently, and therefore experience less pain. So it is working, and I think that's the point to reassure yourself with. It can be quite a hard thing to hear, perhaps, especially when you're, if you've just kind of learned about pad, or not had it for too long. I can totally understand, that wish to make it go away and go away immediately, and that kind of almost that promise of surgery as potentially the solution that does that. I think you have to, what we do know, however, is, well, two different things. The first, and this kind of came up in a meeting I was in earlier today, actually, but the kind of natural progression or history of PAD, or people who have claudication, actually, the majority of people, once diagnosed, their pain will either stay the same or get a little bit better over the course of the next few years. So as you're experiencing now, that pain's getting better, and it will be quite stable. Unfortunately, it will never go away completely, but it can improve, and it can improve to such an extent that it doesn't really impact your day to day. There are, and there are some, however, but a very small amount that do continue progressing in terms of, and the pain getting worse. And that's all related to the management of the other risk factors. As you're mentioning, the taking of the medications, addressing diet, smoking, and other things as well is as important as the exercises as well. The thing about surgery and people being offered surgery first, it's quite a concerning thing to hear if that is the case, because again, that goes against guideline advice, and because of what we know from the evidence, because there's been a couple of studies that are going out there that have said that, if you have surgery early, or, a surgery, often, the repair is never as good as the original. The kind of, and the fact of having to go in, you're addressing a symptom rather than kind of fixing the cause. So the cause being this atherosclerosis process that is kind of narrowing and hardening your arteries. So that's why that all the guidelines recommend the conservative treatment first. And when I say conservative treatment, that's your medications, your lifestyle kind of changes in terms of diet, in terms of smoking, in terms of managing blood pressure, managing your diabetes if you're diabetic as well, and walking. So that is all what's recommended first. If that doesn't work, that's when surgery is an option. But it's only once all that other stuff has been tried and shown not to work. And it's not, and what the really important thing to remember and to grasp is that it's not being fobbed off. It's not being like, oh no, surgery's too expensive, and so it's not, we'll keep that as a last resort. It's because surgery comes with risks, and it's those risks that we want to avoid in the first place. So yeah, it's a really difficult kind of thing to get your head around, all of that.
And it's also, I mean, it's not, when you have a procedure, like, that's not mutually exclusive. Like, you can't, I mean, the only reason to have surgery is to, one, heal the wound, and two, give you enough relief to get you on your feet walking to grow your collateral vessels. It's not a cure. It's not the end all be all. It's not durable. It's just to buy you some extra time to literally create your side roads. It's not a matter of if these procedures will fail, it's a matter of when. And in some of our groups, so many people say I'm like Miss Doom and Gloom and I'm a fear monger and, raining on their parade. But I'm just sharing the truth. That is the truth. You still have to walk. You still have to control your blood pressure. You still have to get your diabetes under control. You still have to stop smoking because that is what's critical. That's what's going to change the course of your life. That's what's going to improve your prognosis. And if you literally have a procedure and you have not controlled your blood pressure, you have not controlled your diabetes, you have not stopped smoking, that surgery, that intervention is only going to fail sooner versus later. And I've seen people actually clot right back up before they've even left the clinic and had to have been brought back in because they didn't stop smoking before they went in for their intervention. So walking is literally, like, we're not even kidding. I think Dr. Cindy, you said it well. It's not like they're trying to save money. This literally, there's level 1A evidence. It works. And Lynn is one of those that is proof of that. Kathy is proof of that. Patty is proof of that. It really does work. It makes a huge difference. Our bodies are miracle workers. They can grow new vessels. Sorry, that was my soapbox. So I want to end with Kathy just sharing her experience. We're going to go back to what we started, which is we want to learn more about the patient experience, create the change we want to see within the system. And we want to have Kathy share her experience in being interviewed by Catherine and hopefully many, many, many more. I want to see 20 people come your way, actually, to share their stories with you. The more, the merrier. We would love to hear so many stories and different experiences across the UK. So, Kathy, what was it like during the interview that people can expect when they participate with Catherine?
Hi, well, Catherine was a very good interviewer. She's a wee bit shy because she hadn't much experience of interviewing, but I had reassured her that people are desperate to tell their stories because they feel abandoned and hopeless, generally, is the experience. And they can't believe they're left like this. So people will be falling over themselves if they realise that they get the chance to say how they felt when they got their diagnosis and how they felt their treatment had gone. A couple of sort of standouts from the interview. As Catherine said, she's changed some of the questions. I might have taken her off course. Stuff comes out that maybe were in her questions later, but you're saying them because they're contextual. I was a bit peculiar because I'd already had the heart disease, so I already came to the pad experience 8 stone, very active, running races, never smoked. So the modifications are very limited, narrow. So I was a wee bit not the normal patient. But I do believe that when patients find out they have this, they're still keen to do whatever it takes if they knew what it was they were to do. But being interviewed with Catherine was nothing but a pleasure, really. The one thing I would say, because just on a side note there about collaterals are durable, because I know this because I have collateral in my heart that was built from my heart attack in 2000. And when my other remaining artery needed stented this year, 26 years on, or 28 years on from the surgery that I'd had, they didn't know if this closed artery was what was causing the problem. So they fixed the one that wasn't the closed artery. The closed artery is still closed. This other artery was supplying the collateral. And after they stented the other artery, I'm back doing everything I was doing before. So those collaterals have endured for 25 years. and they're ready to kick in when the demand was there.
Yeah.
So there's no reason to suppose they wouldn't do the same in legs. It's just they're a bit narrow. So it's this kind of belief in the abstract is very hard for people. But as the years have passed, it's easier for me. And I think what Chris said was very important. And I think that's one of the things that patients are not getting. They're not being given that positive news that, you know, only a tiny percentage of people at diagnosis will end up needing an amputation or having them. A huge majority of people will not. They just have to live with this. So it's about the managing to live with it. And I think that people's diagnosis experience is so bad because they come away thinking they've been given nothing, and they look up Dr. Google now or get told nothing. I mean, and I think that's the sort of thing that Catherine will harvest. I mean, my experience was bad at diagnosis, very bad. And I gave it all. And one of the things she asked me about at the end was what had made the difference. Who had made the biggest difference? And aside from meeting Chris and his team, which has made a difference to my life, no doubt, and joining this group, which has been great, I'd been living with this for a long time. The person that made the difference was me. I made the difference. And you have to say to yourself, if you're the person making the difference, how does that fit in with the NHS offer?
Yeah.
You're only looking for support.
Perfect. Thank you so much, Kathy. We really appreciate you, and we appreciate you bringing the opportunity to all of the folks in our group. And I'll let Catherine just final thoughts here, and one last chance at the end of this video to give people a call to action to join you in this research project to, again, create the change that we want to see.
Yeah, thank you, Kathy, so much again for talking to me. I learned so much from it. And also just from this session, I've already had the opportunity to learn from the people who shared their stories, which is just amazing, and just really what I'm hoping to do. My dearest wish is really that if this all goes the way that I hope, I can really come out with a final result that says these are the things that matter to people, and this is their experience, and that can hopefully be a catalyst for just improving it for everyone is the dream of the project. So anyone who is willing to chat with me and willing to share their experiences, it'll really help, and hopefully we can get the ball rolling on some changes and some improvements in the system.
And again, your email?
CNAGEL300@caledonian.ac.uk. I can pop that in the chat if that's helpful.
Perfect. Thank you so much, Catherine. Thank you so much for the
so
opportunity
much.
and presenting it to us, and you know, including us in this very important research.